Hi, I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Vincent Timpone, an assistant professor of radiology at the University of Colorado Anschutz Medical Center, and he'll be discussing with us his recently published AJR article on neurovascular imaging after TIA. Dr. Timpone, thanks so much for joining us.
Oh, thanks for having me. It's a pleasure to be here.
To start us off, what are the current recommendations for neurovascular imaging in patients with TIA?
So the current recommendations across various society guidelines, first published by the AHA and ASA, were that they recommend brain imaging. And that's preferably done with MRI, but you can also accomplish that with CT, and that's to make sure you exclude any stroke or TIA mimickers. And then you also want to screen the intracranial and cervical vessels to look for high-risk vascular pathology that can be treated to modify stroke risk factors. And the vascular imaging can be accomplished with CTA or MRA in the brain. And for neck imaging, they consider CTA, MRA, and carotid ultrasound all equivalent.
Turning now to the study at hand, tell us about the data source that you used.
So we used a Medicare data source. So the majority of our patients are all 65 and older. It's 100% file of all Medicare claims in the nation for years 2016 and years 2017. So we have two years worth of Medicare data.
And who did you define as your patient sample, and how many patients did you end up including in the study?
So we searched for patients within a Medicare data set that were coded with a primary diagnosis of TIA upon their ED encounter. And those patients had to have some sort of brain imaging, either with MR brain or a CT brain. And ultimately, we ended up with approximately 111,000 patients.
And in that patient sample, how did you define a complete neurovascular imaging workup?
So patients were defined as having complete neurovascular imaging workup if they had any sort of brain cross-sectional vascular imaging with CTA or MRA, and they had any sort of cervical neck cross-sectional vascular imaging with either MRA, CTA, or carotid ultrasound.
And then what did you find in terms of the proportion of patients who had complete versus an incomplete neurovascular imaging workup after presentation?
So we found that approximately 37% of patients presenting to the ED with a primary diagnosis of TIA did not have neurovascular imaging within their ED encounter or within 48 hours of that ED encounter, as recommended by guidelines.
And what was the association of an incomplete neurovascular imaging workup with subsequent stroke?
So patients with incomplete neurovascular imaging workup, we followed them for 3 months, and we found that they had an increased association with stroke. 7% of those patients had new stroke diagnoses, as opposed to approximately 4% in the patients that had a complete neurovascular imaging workup.
Now, in coming up with that odds ratio, you did control for a variety of other patient and hospital characteristics. So what were some of those?
So some of the patient characteristics were high-risk comorbidities, like atrial fibrillation, hypertension, diabetes, hyperlipidemia. We looked at race and ethnicity. We looked at median household income based on the county the patient lived in. We also looked at some hospital characteristics, so hospital size, whether it was an academic center, amongst others that are in the paper.
In a secondary analysis, you did also look at whether those characteristics were also associated with stroke, and what did that turn up?
So some of the secondary analyses that we found were in line with prior publications. So patients with lower income and some hospitals that were smaller and in rural locations were associated with increased risk of stroke, as well as some high-risk comorbidities as well.
So given your findings, what do you recommend should be done?
Well, I think this is an opportunity for facilities and clinicians to evaluate their own TIA imaging practices and see if they're in line with guidelines, because we're suggesting here that there is an association with incomplete neurovascular imaging and stroke.
Are there any key limitations of the study to highlight?
Yeah, I mean, this is a study of large administrative database, so it is relying on the accuracy of the TA diagnosis and accuracy of codes, which can be subject to error. And we're only looking at outpatient TIA, so the study is skewed towards lower risk TIA patients. However, it does represent the large majority of TIA encounters that are often just worked up as outpatients.
Any final takeaway for our listeners?
Yeah, I think it's just an opportunity for clinicians and facilities just to reevaluate their processes and make sure that they're in line with updated TIA imaging guidelines.
Dr. Timpone, I really appreciate your coming here and sharing your insights with us.
Oh, thank you for having me. It's a pleasure to discuss this work with you.